Good afternoon, everyone. This is Tony Trahan with the Office of Mental Health. Thank you all for attending this webinar on integrating peer staff into the workforce. A brief orientation to webinars. Due to the volume of participants, we do have to keep the lines muted, but feel free to ask questions via the chat function on the webinar control panel. And we'll bring that slide up right here. So you can see where the arrows are. If you just press on that where the arrow is pointing, and that will open up the chat box, and then you can just send me a question, and I will be monitoring the questions throughout the webinar. During the webinar, you may experience momentary lapses in the audio. This is normal and should not interfere with the overall content of the presentation. However, if you are at a site that has low bandwidth and you are experiencing continuous dropouts, we do have a teleconference that is running, and you can access that by pressing the chat function, and there will be a welcome message there, and you'll be able to see the number there. This webinar is being recorded and archived. We'll post this with our other recorded webinars on the YouTube site, and you will also receive a link that will automatically you will also receive a link automatically in a follow-up email. Please feel free to share that link with anyone else in your agency or anyone that you feel is appropriate. We currently have 140 people on the webinar right now. We'll probably get some more as we go on. When the webinar ends, you will receive a short survey. Please take the time to fill this out. Everyone attending today will receive a certificate. At some point, we are running a couple months behind on that, so I do apologize, but we'll get those out to you as soon as we can. If people are sharing a computer to view the webinar, please list all the people requesting a certificate, and it will all be sent to you as attachments in one email. So for today, we have John Allen is our presenter for today. Mr. Allen is a noted speaker and author on disability rights, entitlements, and homelessness, disability employment, and recovery. He is committed to ensuring that recovery from mental illness is possible for everyone. Mr. Allen served as the Special Assistant to the Commissioner in Maryland from its inception in 1995 until 2002. Under his leadership, there was a remarkable 300% increase in consumer-operated services in the state of Maryland. In 2002, Mr. Allen came to New York State, where he served as the coordinator of outreach for the New York State Project Liberty. His role was to ensure easy access for special populations to the education and counseling programs provided by FEMA after the 9/11 disaster. Currently, Mr. Allen serves on the executive staff of the New York State Office of Mental Health, where he is the Special Assistant to the Commissioner and the Director of the Office of Consumer Affairs. In this function, he is responsible for the development, implementation, and evaluation of numerous activities to support policy program and quality integrity, financial stability of programs, mental health, consumer family inclusion, and recovery. Additionally, his current role includes providing program oversight, management, and technical assistance to over 200 community-based providers. His federal training credentials include recognition by the Department of Justice as an expert on ADA issues, and he has edited, authored, and co-authored numerous technical reports on a variety of mental health topics. Many of these can be found on the National Association of State Mental Health Program Directors website, which is www.nas, as in Sam, M as in Mary, H, P as in Peter, D as in dog, .org. That's www.nashpid.org. And then on a personal note, as a peer who is part of John's staff, I can say that this presentation today is not academic or theoretical. John has daily personal experience in supervising and integrating peer advocates into the workforce in a way that is mutually beneficial, fair, and wonderfully challenging for both peer and non-peer employees. And with that, I turn it over to you, John.
Great. Thank you, Tony, for the welcome and introduction. Let me start, and just for those of you that may not be familiar with the webinar process, just make sure that you know a couple of the functions. Tony already went over, if you want to ask a question, we ask that you document it in the question and answer chat log. That's so that if we don't get to answer your question during today's webinar, we can follow up with you afterwards and be sure that you're able to get the answer to your question. Secondly, if you're unfamiliar with the webinar process, you can minimize what's called the webinar control panel by clicking on the arrow pointed to the right, which will hide most of the screen so you'll be able to see today's PowerPoint. And when you need to ask a question or chat with one of the staff, you can click on the arrow, which will then be pointing to the left, to actually expand the webinar screen so that you will be able to, in effect, create your chat or your question and answer dialogue. So let's jump in and talk about the effectiveness and why you may want to hire peer staff and how you might go about it. So at the end of today's webinar, we'll certainly provide an opportunity for question and answers. And throughout the webinar, Tony will be monitoring the question and answer dialogue and prompting me to respond to questions as they come up if I use an acronym or something else that I don't particularly catch. So let's begin and kind of talk about the case for why you might want to hire peer staff. Well, first, there's a couple reasons that really affects your provider, your organization, of looking at the competitive edge. Hiring qualified employees is the #1 staffing issue cited by all employers, and particularly those that are providing human services support. The Annapolis Coalition a few years ago actually cited the problems with hiring qualified staff and retaining them as the most serious problem facing human service providers in the current environment. To remain competitive, you're going to need to look beyond the traditional labor sources to find those skilled, qualified, available candidates. And this includes focusing on these alternative recruitment methods that we're going to talk a little bit about today. And particularly what we're talking about is when we say that we're not able to hire staff or we're not able to find qualified, competent people, most of our state systems of care actually have several 100,000, in New York's case 640,000 individuals who have extensive experience in the mental health system actually as part of our service continuum. And so to look within that realm, we may actually be able to find individuals who are not only qualified but competent to assist us in a variety of ways. So let's kind of look at what's the evidence of why we might want to hire staff, aside from it being politically correct. There's several studies and citations that I just want to point out to you that point out the fact that peer support, whether delivered directly by a peer in terms of a self-help or peer support program, or as part of a more traditional treatment provider where there are staff who are identified as peers to provide support, can overcome a lot of the barriers to both engaging individuals in traditional services and support, as well as changing the outcome process to actually achieve better clinical outcomes in a variety of ways. And so you can look at the study here that peer support has been demonstrated as effective in terms of clinical responsiveness in the areas of substance abuse, parenting, loss, bereavement, cancer, and chronic illnesses, as well as some of our own terms of mental health support. There was a group that convened nationwide at the Carter Center several years ago that created a document called the Pillars of Peer Support. And after today's webinar, we'll share a number of these documents with you, so you'll have both the evidence that I'm citing as well as the core documents themselves. The group that got together at the Carter Center identified, and they were mostly focused on certified peer specialists. It's a particular type of peer, typically in other states related to Medicaid billable peer services. But really, some of the core things that they identified really apply to hiring peer staff in general, not just those that would be Medicaid billable people. And so here, if you look at their report, that they said that these are really important parts of the mental health treatment teams and settings for care, which include mental health centers inpatient, outpatient settings, emergency room, and crisis centers. And there's a variety of reasons why we may want to look at adding peers in the most traditional treatment setting environments that we'll get into momentarily. They went on to really talk about what differentiates these peer roles from traditional providers is that their knowledge and competencies in providing support are really built out of lived experience. And from that, they have, if the right person is hired, the ability to help translate between more traditional service providers and the peers that we serve by being able to bridge the language that we use in mental health treatment settings. And so within the variety of studies that are cited here, they point out that peer specialists, in whatever the role you call for your peer support staff, are really uniquely qualified to help individuals in identifying goals and objectives in this context of what's being called a peer support relationship. Now, that changes the nature of how we look at our more traditional services, which again we'll get into in just a minute or two. So I want to begin making more of the case here and just giving you a couple of other studies that actually look at why, from a clinical standpoint, do we want to consider bringing peers into our clinical settings. And here there's a lot of evidence which suggests that peers as part of hospital-based care have actually shortened length of stay, decreased frequency of admissions, and a subsequent overall reduction in treatment cost. And particularly for those of you that are concerned about today, the competitiveness of your agency as we're moving to a managed care environment, this overall cost savings and the benefit of having peer staff to help both engage clients on the front end and reduce some of the long-term utilization process on the back end can make your agency more competitive as you think about the future in managed care. So let's look at why you might want to have peer staff. And so I think there are some common reasons that we've heard that you may want to consider hiring peers. One is simply affirmative hiring and employment creation. If you're having difficulty hiring staff in a variety of ways, peers become an excellent opportunity to expand your workforce potential. Certainly this whole concept of role modeling can be critically important. Now, I say role modeling because it's role modeling not just to the people that you serve. Many employers often say to us, well, you'd like us to hire your peers, but how many peers has your agency hired? So you're telling me it's good for my business. Show me how it's good for your business as well. And so if you're not role modeling that we really do value the people that we serve and are putting them in a variety of opportunities and positions, including leadership positions within our organizations, how can we expect other organizations that we may want to influence in terms of hiring peers in general if we're part of an employment process or supported employment setting, if we're not practicing what we preach? And so role modeling is particularly useful for employers to say, you know, we have experience hiring the people that we serve. Here's what we've learned from that. It's equally important for the individuals that you provide services to as well as their families. Many families, and in fact, many people who use mental health services, become often engaged, as do our staff, in the anecdotal evidence that people don't recover. And I say that, and I want to make this point because it's critically important that we achieve the results that we expect to achieve. And so if we don't challenge ourselves regularly to think about what's possible for the people that we serve, we often set artificial ceilings for them, and they often set artificial ceilings for themselves. So people coming to a day treatment program who've never seen somebody like themselves who's working, who's raising a family, who's employed, who's going out in the community in general, will create an expectation from the peers that they're in program with of continuing to be in program forever and never challenging themselves academically, financially, emotionally, or in their own recovery to advance beyond the status quo. Families likewise are often confronted with never seeing people who are in recovery to the extent that they can honestly believe that their loved one can achieve possibilities. Having direct staff who talk regularly about their own experiences and are open and honest about that can provide an opportunity here. There are a couple of other reasons for thinking about and hiring peer staff. One is the unique perspectives and contribution that peers can make to the team, and I'm going to talk a little bit more about that in a few minutes. And the last reason is one that may not be immediately, intuitively make sense to you, which is employees with disabilities generally have higher retention rates than non-disabled individuals. Now, one could argue that's because they're so appreciative of working, but when their work is meaningful and valued and when they're able to make a difference for other people with disabilities, sometimes that far outweighs both the wage and the opportunities that are presented to people. Now, I don't want to imply that we should be hiring peers at less than full competitive wages, but that turnover rates of all staff in human service agencies are profound. And if we can affect that even in a small way, that reduces our overall agency cost in hiring, recruiting, and training staff. So what can peers bring to service delivery? Well, the first is really a dedication and commitment to work. Now, some of this becomes both personal growth, but also an individual who's been through the system, who sees the value that services can create, really becomes dedicated to sharing that information in ways that make this personally meaningful to them, besides just having a career. The ability to create this immediate connection with people that they serve is often the reason that we engage peers in outreach and engagement processes. We tend to have people who have experiences like us have the most credibility. And so thinking back to our disaster experience in New York State, reaching out to police officers, it was important to have police officers do the outreach. And reaching out to the fire department, it was important to have people who had been part of FDNY to be able to reach out to people in the fire department. Likewise, if we were to translate this to other health areas, it's equally important to have a cancer survivor reach out to other cancer survivors, or even in terms of bereavement, a suicide survivor reach out to other suicide survivors as part of the care that we generally provide. And so similarly, having peers in your workforce creates a possibility of immediate connection. But that possibility is really only if you think about how to use their stories and lived experiences to provide and inspire hope. So we'll talk about that more in a couple of minutes. But I want to really resonate on that, because if we simply hire peers because we think it's the right thing to do, and then we don't provide the mechanism for them to use that lived experience in ways that are meaningful to them and the people you serve, then we're really missing the huge opportunity that presents itself by building on that lived experience. Now, the next bullet talks really about the ability to bridge and engage other providers on the treatment team. One of the things that I typically ask in clinical settings as I'm visiting our hospitals and other environments is, can you name, and I'm going to use a little shorthand here, for those of you that are peers on the call, you'll understand the shorthand, and those of you that are providers will immediately understand the shorthand. But I'll typically ask providers, can you name the top 5 frequent flyers that visit or use your facility? And staff can immediately rattle off not just 5 names, but usually many more than that. If I ask them to similarly name 5 people who've recovered as a result of receiving their services, most staff at most provider sites are hard-pressed to name even one or two. Why? Because out of sight means out of mind. And once people do better, we often forget about the good work that we've achieved and the good benefits that we've done by providing clinical supports. And staff get demoralized because they remember the people that are in front of them every day, and they remember the frequent flyers. So having staff there who can remind them of the good work that we've all accomplished individually and collectively becomes a huge benefit for peers to be able to help bridge the anecdotal evidence, which is the whole reason the newspaper headline said, Dewey wins. We used the convenient evidence of what was available, not the actual evidence of how many people actually do recover. The ability to guide people in accessing community resources and services. Well, case managers are pretty good at knowing what services and supports are available through the mental health system and the other formal treatment systems. But peers who've lived on SSI or SSDI know how to stretch a dollar in ways that some of our professional staff may never have had to do before, and know the non-mental health resources that are available in your community that can enhance and expand the opportunities for the people that we serve. The ability to model healthy relationships so that others can replicate them in the community by being trustworthy is pretty obvious. And the ability to demonstrate to family members and other supporters that people like their loved ones can recover. When I'm talking to family groups, I'm often confronted with family members who say, well, you're not like my Johnny because my Johnny is has a serious illness far more worse than you are. That's the reason that we need more people in recovery to be able to explain their stories and be public about them so that families and the loved ones that they care about have not placated hope, but have real hope for the real possibilities that with the right supports and the right services that their loved one can achieve a measure of recovery. So how do we go about creating the presence of peers, and what does that mean for us? Well, peers can bring a different perspective to treatment team members during treatment team meetings. And I often think about my own experience of being part of treatment teams in the early days of my career, where I would translate certain behaviors that clinicians would find symptomatic to the practical thing that peers were going through at the time in their lives. Lauren Mosier, who's written and was considered or is considered the father of the schizophrenia bulletin at NIMH, used to say regularly that sometimes anger is just anger. It's not necessarily a symptom. And having peers who aren't focused and wedded on the clinical aspects of things can sometimes say, well, you know, that person has a right to be angry, and their expression of anger is not outside the normal bounds, to remind us all that people are, in fact, still humans. Supports in the use of recovery language is something that we often get into, and we don't mean to, but we talk about the SPMI or the CMI or chronicity in mental illness. And yet we don't often think about how that translates to the people that we serve and what that's really saying to them, that you're really not able to recover.
So, John, could you just clarify what does SPMI and CMI mean?
Serious and persistent mental illness or chronic mental illness, kind of shorthand that we've used for decades. And the last, as I've talked about before, is peers in the workforce can provide living proof that people can, in fact, do recover, not only for the peers who are served by treatment teams, but for the staff who are on the treatment teams themselves. So, before we get in to begin talking about, are we going to hire peers, I want to talk about what I call the red herrings that I hear from so many people of why we can't hire peer staff. And I say these are red herrings because, in my experience, they really are that. So the first red herring that we often hear about is, well, I can't hire peers because of confidentiality. People cite HIPAA and HITECH. Having actually read every bit of those statutes, I would challenge any of you to point out where in those documents does it say you cannot hire someone who has lived experience of using your services. And in fact, they say just the opposite. And so HIPAA and high-tech, certainly we have to train peer staff. They have to be knowledgeable about the confidentiality provisions. But the fact that we have a receptionist who equally needs to be trained about HIPAA and high-tech should not be the reason for barring the receptionist from talking to people on the phone because they might hear somebody's mental health issues or concerns. And this particularly plays itself out in small rural communities in ways that get very bizarre because, let's face it, in a rural community, most of us that live in rural settings, and I live in one, I don't get mail delivered at my house. We're so small, you have to go to the post office to pick it up. Quite honestly, if you want to know anything that's going on in my community, you go talk to the postmaster because he knows everything that's going on with everybody. Confidentiality in rural communities is somewhat of a myth because we know pretty much everything about folks. Now, that's not to say that we should be talking about the clinical aspects of treatment outside those treatment settings. But this is a red herring that we regularly use to say, well, we can't hire peers because they'll violate confidentiality. And that clearly is not only not true, but it potentially violates EEOC and the Americans with Disabilities Act and could subject you as a provider to litigation and lawsuit. The other sort of red herring is role confusion. I'm going to talk a little bit more about that as we talk about designing roles and the opportunity for creating the job structure. But one of the things we often talk about is if I'm serving someone, then clearly if they're also staff at certain times, they're going to be confused about what their role is. And so they'll be sharing things that they're not supposed to be sharing in other ways. Quite frankly, that happens with our professional staff as much as it happens with peer staff. I don't attend a social function with clinicians where we're often not talking about the people and services. I would suggest to you some of that's appropriate conversation, but from the hat that I wear, some of it is clearly inappropriate when we start talking about enough specifics that the individual is potentially identifiable. And yet regularly that's something that we do in the clinical settings, not in the peer settings, but in the more clinical settings. And so the red herring of role confusion is one that we need to be clear on confidentiality and patient privacy rights and protections.
So John, let me just ask you a question though about the confidentiality. I mean, if we are talking about people in rural towns and they want to hire peers, they may be, I mean, those peers may be receiving services from that facility.
And on this issue, I want to talk a little bit more about that in a minute or two because I actually have a slide there that I want to bring us to.
Okay.
And I want to lay a little bit of groundwork before we get there and talk about, so why do we want to hire peer staff and what might be involved in that? Well, part of the decision to hire peer staff obviously is top management. So top management needs to make a decision, is this right for our agency? But I would suggest if you're going to do this, you need to really engage a lot of the staff into how do we create a culture within our organization that makes it friendly for people who might have a different set of experiences and background. And it's critically important that all of the staff have bought into the fact that we're going to have people who are different. Just as if we've never had someone who uses a wheelchair before, it creates some differences. Now, do we have the staff say no? Well, that would violate federal and potentially state law. But we need to have staff understand why we're looking to hire peer staff. What do we hope to get out of it? What do staff hope to get out of it? Otherwise, they can very easily sabotage the entire process. Now, by saying sabotage, let me give you a couple of examples. The easiest way that staff sabotages, staff often get together outside the work environment for social events. And yet if you have a peer staff person who's not invited to be part of those gatherings at people's homes because We just don't think about them in the same way that we think about other staff. We create an environment that, under the federal EEOC guidelines, could be considered hostile to the individual. Now, you don't mean for it to be hostile, and people's relationships often develop over time, but we need to think about, within both the work environment and the non-work environment, how do we make sure that our environment is user-friendly? And that includes to all of our staff, whether they have a disability or not. So let's talk about creating the position, because before you hire a peer person, you need to define what it is you want them to do and have some clear expectations of, why am I hiring a peer as opposed to a non-peer? If I'm hiring a peer to be the van driver, what's the point of having a peer if they're not going to be using the unique value of that lived experience? Now, if part of the value of the van driver is to engage clients who may be having a difficult day and help set up that process so that people are willing and effectively able to participate in treatment, that may be a useful enterprise. But we don't just want to hire peers for a position and then call it a, quote, peer position, because it diminishes the effectiveness and the knowledge that people have gained from the lived experience of living and surviving and recovering from a psychiatric disability. So as part of creating the position, we want to consider the advantages of having that peer staff and maximizing the utilization of the unique tools and skills that they can bring. Outreach and engagement is sort of the obvious place that we may want to consider hiring peer staff. But as part of clinical treatment teams, having peer staff be part of the integral treatment team planning process, helping the individual plan for what they need from treatment and help translating from the clinicians to the peer, and building the support skills like RAP plans and other things, can create an added benefit to that process. But we need to be clear on that up front. We need to consider up front, before we hire someone, the potential need for ongoing peer support. In most of our clinical settings, clinicians have the networks and guilds of other clinicians to be able to get support when they encounter a challenge or a problem that they're not used to facing. When we hire one person who has lived experience and we make them an island unto themselves, we set them and our agency up for failure in that process. Because who can they go to talk to about what they're struggling with around disclosing their disability, answering issues about reasonable accommodation, dealing with interpersonal relationships with others in the same way that other professional and paraprofessional staff have each other to work with. In the OMH system and in our more structured systems, we have lead staff. So we have a head nurse, whether supervisory or not. We have our head social worker. We have our head psychologist. And they're the head of the guild, which brings issues related to the guild together to help people resolve those issues. If you're going to hire peer staff, you need to think about, where does that peer go to get the unique issues of them being in this different environment addressed. It may be inside your organization or it may be outside your organization. And if it's outside, how are you going to deal with the issues related to some internal concerns that you have? So what opportunities do you have to set up for peers to get peer support to address their concerns, where we don't exacerbate HIPAA and high-tech, which could be a real concern if we've not thought about this in advance.
Now, John, I have a question about that, because I did have an experience where the peer staff were actually required to go and get support. So they were required to go to one of the other programs that the agency offered, and I don't think the other staff were required to do something like that.
And so in that kind of case, what you're describing, Tony, is actually a setup where the provider could unknowingly be violating EEOC and the Americans with Disabilities Act, because you can't require someone on the basis of a disability to do something that you're not requiring all staff to do. So if all staff are not required to use other support, then you shouldn't be requiring peer staff to use a different kind of support. But as you're developing the position, you need to think about where might a peer go if they want and need that support, and set that up in advance so that you're not creating it ad hoc afterwards. But that's different than requiring someone to use it, which potentially is going to violate several sections of law. Now, the last piece that I have on here is supervision, because part of creating a peer position is having a supervisor who's going to supervise and understand the unique contributions that we want the peer to make, not just that we're supervising them the same way we supervise everyone else. And part of the reason that I bring this up is that boundary issues with licensed clinicians often become problematic for providers to think about peers in a different way. The value of hiring a peer is for them to share their lived experience as part of engagement, role modeling, and other behavior. For most of our licensed clinical positions, sharing your personal experience is considered taboo. And so having a supervisor who understands the unique nature of this position and what do we want as an agency to accomplish with it becomes critically important to the success. So once we've identified what do we want a position to do, we want to think about how we're going to recruit people and where might we find people to fulfill the job opportunities that we have. Well, we may want to recruit simply to include people with disabilities in our diversity recruitment goals. So if your agency's ever been charged with EEOC violations, you know that one of the defenses is that you've got diversity as part of your overall human resource strategies, and that you're paying attention to the diversity within your workforce. And that includes people with disabilities. You may want to think about creating partnership with disability-related advocacy organizations. And this becomes important for that opportunity for peer support outside the workplace. If we've got an MOU with our local peer support group where we're going to do referrals back and forth for clinical and support services, then we may want to think about an opportunity for the staff in that peer support group and the peer staff who work in our agency to potentially be available to support each other. And think about that in terms of the MOU. We may want to contract with career centers at colleges and universities as vacancies arise. Now here, if you're regularly recruiting people, you're probably familiar with the college's normal recruitment offices. But at most colleges and universities, there's also an office of disability assistance frequently to provide students with disabilities support and encouragement that they need. And going through those offices, you can often find regular opportunities to recruit people with disabilities. So posting job announcements and disability-related publications, websites, and job fairs. And thinking about, really even before you get there, establishing internships and mentoring programs targeted at youth, but not just youth, really at any individual with a disability. How might we have people start interning at our program so that we can understand how best to support them and begin how best to utilize their skills? Now, I want to talk about these hiring considerations. So as you're looking to hire peers, a peer isn't the best qualified candidate just because they're a peer. You really need to pay attention to their competencies. Do they have formal training? Now, formal training is not necessarily all that it's cracked up to be. And I'll point out that Socrates, Plato, even the father of medicine, Hippocrates, did not have a college degree. So when we think about lived experience, mentorship, and the experiential education that our greatest thinkers of the times had and used as the evidence of their credentials and ability, we need to think about peers' experience in the same way. Do they have demonstrated skills and acquired knowledge? It is important for anyone that we hire to have the appropriate knowledge and skills to be able to do the tasks that we're looking at. But don't simply require formal education as the opportunity to weed out those who have profound lived experience and could be extremely beneficial. We often think about, and one of the tools that we've been encouraging peers across the state to use is some of the ability to test out for college level credit from gained life experience. And you can do this through a lot of colleges. In New York State, the Empire State College has that ability. Think about how you might utilize that in your own program. Also, if you're going to hire people with disabilities, think about not using chronological resumes. Because the problem with a chronological resume is immediately it highlights that the fact the person might have been in treatment for a period of time, because they're going to have gaps in their resume history in ways that a traditional hiring staff would weed out those people from employment opportunity. Why? Because we're often fearful that they actually got fired from a job that they're not telling us about. And it's illegal for us to ask them, were you hospitalized or in other ways for this period of time? So thinking about looking at experiential resumes as opposed to chronological resumes, and setting up an expectation that we want to look at your experiences and your benefits, and even look to say that we want to hire people with lived experience. Many providers often tell me, well, that's illegal. We can't recruit people because we can't say that we want someone who has experience using mental health services. Well, that's actually not true. The EEOC provided a lot of guidance, particularly, and you can find it around independent living centers. So independent living centers have a bona fide qualification for employment of having lived experience of living with a disability. And so if your job requires that you want someone to role model certain things, it can in fact be a bona fide occupational qualification. And if you look at the guidance provided actually now more than several decades ago by the Equal Employment Opportunity Commission, you'll find that there's a lot of guidance about this as long as it's a bona fide occupational qualification. Disclosure considerations are particularly important as we're hiring. So if we're looking to hire someone with lived experience, we need to be very comfortable and very knowledgeable about when and how people may choose to disclose their disability. And if we're looking for people to be role models and share their life experiences, then we need to be upfront that that's an expectation and part of the job expectations, as opposed to getting into the conundrum of, well, I can't disclose certain things in the hiring process, which is why we want to make, and we want to think about making lived experience one of the bona fide occupational qualifications. The last thing to consider in hiring is the effect on entitlement programs. And here we want to be really knowledgeable about hiring someone who's living on SSI or SSDI. What effect is that going to have on their safety net? If you're not familiar with things like the Medicaid buy-in, you want to become very knowledgeable about it, because for a person on disability to go off of Medicaid and then risk not having health insurance becomes profoundly disabling in and of itself. And that's usually the number one reason that families are against individuals going back to work, is the fear of loss of safety net. So some hiring do's: evaluate each candidate for the job based on whether he's met your requirements. Well, that's pretty simple, but we often don't do that when we're looking to hire peers. We don't look at education, training, employment skills, licenses. We simply look at, are they a good peer? Do we like them? Rather than, do they have the skills that are necessary to accomplish this task? So if I'm looking for someone who can document case notes, I may want a writing sample. And I may want to provide kind of what a writing sample looks like so that people with disabilities can think about how to respond. We want to consider whether the person with the disability can perform the essential functions of the job with or without reasonable accommodation. That language comes right out of the Americans with Disabilities Act and is a legal requirement of all employers, regardless of whether you're hiring people for a disability-related position. And we want to recognize that there are many ways to accomplish the same task. Just because we say, this is how we want you to do it, there may be other ways that are equally effective that a peer can help you think about. So some hiring don'ts in the process. Don't assume that only certain jobs are more appropriate for people with disabilities. Don't assume that a person can or cannot want a particular job because of either apparent or non-apparent disabilities. We often think that someone coming in isn't going to want that job because, well, they've got and why would they want that job? Let the person make that decision, because to not do that is actually discriminatory. We don't want to assume that a person with disability doesn't have to have requisite education and training. They absolutely need either experiential education and training or professional education and training to be able to be an effective part of a team. There are a lot of ways to acquire knowledge. And so looking at how your agency is going to evaluate, does the individual have the requisite knowledge to perform the task? Don't simply look for the documented sheepskin, but look at ways to actually engage people who may have extensive lived experience and be able to help move your agency forward. Also, don't hire a person with a disability who's not qualified to perform the job. This sends a profound message to all of our staff that this isn't a real job, that we really don't value the peer position, and we really, in some ways, pardon my language, but we don't give a damn about what they really do. We're simply hiring it to be politically correct. If you're going to hire a peer staff, hire them and make sure that they're competent and they're able to perform the tasks that you want. And if they're not, then don't hire them and don't treat them differently than you would a non-disabled staff person.
John, with bullet number 3 there, one of the most common questions that we do get is around credentialing and where peers could get credentialed before they are hired by the agency.
And so in New York State, we have a lot of discussion right now with the peer community who has a lot of issues about credentialing, and rightly so. There's a lot of concerns embedded in it, some of which is really the loss of what it means to be a peer and offer peer support. But that doesn't mean that you can't acquire skills from colleges, community colleges, trade schools, and other settings, or from lived experience of working with, under the tutelage of, or supporting people in a variety of ways. Likewise, the IAPSPRIS certification is one of those ways to document that you have experiential learning, as is Boston University's experiential credentials, and there are others available. So there's a lot of ways to document that someone has experience, and you may want to look at how do you document that they have the skills that we're looking for. So if we're looking for somebody to write, I want a writing sample. If I'm looking for somebody to teach RAP planning, I want to know, are they certified by Mary Ellen Copeland's group as a RAP trainer? There's a variety of ways we can look at the skills. So I want to bring up a couple of things that are unique to hiring peers. And in New York State, we require everyone who works in human services to be fingerprinted and be cleared to work with, quote, vulnerable populations. Now, the fingerprinting process often identifies people who have lived experience who got in trouble with law enforcement for a variety of things. But I would take you back to what I said in the very beginning. If the population that my agency is serving are people in criminal justice who have committed serious felonies, it may be very appropriate for me to hire someone with a felony who's been rehabilitated, who has lived the recovery experience, to have the credibility with other felons to help them move beyond their current expression of symptoms and where they are, but to actually achieve the same measure of recovery. And the fingerprint requirement's not a bar to that. So here's what you need to think about. You really need to understand the process of why we're hiring the person. And if we're hiring a peer position, then we need to create a package when the person comes back that they're denied because there's something in their background that says we're hiring this person for a peer position, and the unique nature of the population that we serve is going to be enhanced by hiring this person who matches the population that we serve. And so one of the examples that I regularly use is if we're serving convicted felons who have been released from prison and correctional settings, then it may make sense for someone who's made that recovery journey, who's transitioned from that setting, who understands all the challenges and risks and can help those individuals and help the treatment team, help those people transition to a different environment. And our fingerprinting process doesn't preclude that. It simply means you need to provide a justification for why is this person's skills, including their experience in criminal justice, unique to this setting. Now, if you're not hiring someone to work with a population like felons, you want to think about what's the vulnerability of the population that we're having the person work with. If they're always working under supervision, then explaining that in the process. If the individual has gone through extensive support, then you want to help explain what the individual has done in their own recovery and help them in that process. Here I want to highlight one of our peer programs in New York State as being the exemplar in supporting these packages, and it's the Howie the Heart program in New York City. So if you're finding that you need to work with individuals who have challenging backgrounds, I would refer you to contact the folks there because they've done an exemplary job of how to help document so that we can make the appropriate decision of how to help the individual meet their needs and recovery goals and objectives. So orientation is something that we need to do with all staff, and so we just need to think about how we're going to orient this peer staff to their new role. And particularly if the agency itself has never hired a peer position before. There are some unique things that we often subtly say to people without even realizing that we're saying them. And so making sure that we have people open and aware that some of our practices may not appear to be user-friendly when you're now hiring a peer staff in ways that you've not thought about before, and just the way that we talk about some things. And how are supervisors oriented to this unique nature of the peer position I've already mentioned. The ongoing supervision and support is critical. So how do we maintain the unique definition that we described to the peer position when we created the position up front, so that the unique value and the reason for us hiring a peer doesn't degrade over time so that they're simply the van driver who just shuttles people around, and we've lost all the unique value that we originally wanted to hire in the first place. That's a supervisory issue. How do we provide that ongoing staff support? And how do we ensure ongoing professional development for our peer staff in the same way that we support ongoing professional development for all of our staff so that people don't get locked into a position and be there forever without enhancing and developing additional skills? One of the biggest issues in hiring staff is this issue of reasonable accommodation. So I want to just touch on it just a little bit. Is once a person with a disability becomes part of our workplace, then there are many resources available to help you in that regard. So many of your employees experience an illness or injury that can compromise them on the job. And so understanding the value of accommodations and how they're typically not overly expensive, in spite of what many of the fear-mongering practitioners who want to sell their services around accommodations are evil say, most accommodations, according to the federal government, cost less than $100 and can be provided with a minimal disruption in the workplace for people. And employers can often save money by tapping into the resources that they learn about for reasonable accommodation with their people with disabilities for all of their employees. So simply making an environment a little more user-friendly for all employees often has profound value. So how do we decide what's a reasonable accommodation? Well, the process for addressing this is both informal and what are called conversational reasonable accommodation requests. An individual who needs a flexible work schedule to be able to attend a psychotherapy appointment on Thursdays at 2 o'clock might be a reasonable accommodation. It may also be reasonable to try to get their psychotherapy moved to Thursdays at 7 o'clock. But think about your own services. How many of you really offer evening and weekend hours for the clients that you serve? And so think about the staff employees who you're now going to hire, who you're going to say, well, of course you can get an appointment at 7 p.m., or why don't you go on the weekend? Show me the number of clinics that have extensive evening and weekend hours to support anyone who's working, let alone peer staff. So we need to be flexible in how we think about reasonable accommodations, and that's what the law requires. There are actually some wonderful supports that can help you think about this. So if you're not familiar with JAN, I want to focus you on the Job Accommodation Network. JAN is operated out of the University of Wheeling, West Virginia, and provides a toll-free service for the variety of accommodations that you may not even be aware of. So if you're working with an individual with a disability and they need an accommodation in an area and neither you nor that person with the disability knows what the accommodation needs to be, looking at JAN for help, guidance, and assistance can be immeasurably helpful. Now, I want to caution you here because I've used these words very carefully. You cannot require a person with a disability to use an accommodation. That is illegal. It is also illegal for you to impose an accommodation on an individual. They have to request it. Now, as part of supervision, if the person is having trouble accomplishing their job, it's absolutely appropriate for me to say, it appears that you're really struggling with this. Can we look at ways that you might be able to accomplish this task differently? Which we should be doing with any employee who's struggling with a particular task, not focusing on accommodation, but how do we structure the job so that they can be most effective in that regard. So, a couple facts about reasonable accommodations. Well, the March 2003 study of employers found that most accommodations cost less than $500, and 73% of employers reported that their employees with disabilities did not even require an accommodation at all. So don't presume that just because we're going to hire someone with lived experience that that's going to become one of the things that we have to pay attention to. So I want to take a few minutes and talk about some of the potential traps as we think about hiring people. I want to begin with tokenism. Anytime we hire one person, they become our token or pet person in recovery. If we're really going to think about hiring people with lived experience, how do we do so in a meaningful way? Now, if I only have 3 staff, hiring one probably is the best I can do. But if I've got 103 staff, hiring one, given that 20% of the population are people with psychiatric disabilities, probably is not meaningful or reasonable. We also don't want to presume that the person that we hire with the disability becomes the spokesperson for all people with disabilities or all of the people in our program. One of the traps that many programs get is we're going to hire a peer staff who becomes the complaint and grievance department for all the peers in our program because, of course, they'll understand complaints and grievances. We also want to be clear that we don't co-opt the individual. So being a peer staff is a fine line to walk between being credible and valuable to the people that you serve and being credible and valued to the staff who you work with. Don't ask people to join one side or the other. Help them understand how to walk this tightrope in a way that makes sense so that you get the best of both worlds. And the very worst thing that we can do is take a paternalistic view of looking at the peer and saying we need to take care of them and protect them from unnatural consequences or even natural consequences. Peers should be disciplined like every other staff. If they're having a difficult time, then referring them to employee assistance or other places where they may get their needs met is important. But to say I'm not going to discipline somebody who's not doing their job because they're decompensating does a disservice to all of our staff and does a disservice to the credibility of hiring peers in the first place. Now that said, we don't want to, as part of the discipline, say, well, you have to go here or you have to go there. We want to talk about the behavior that is problematic and then ask the individual, so how are you going to deal with this? Because it really is up to the individual to own the responsibility for their behavior, even if their behavior is symptomatic. And they need to take the responsibility. Now, oftentimes as clinicians, we get into diagnosing people. And I want you to be very careful that when we're an employer, we don't trade our hats, because the law is very clear and there is a very fine line. We don't diagnose our employees, even when some of them get treatment from us. As an employee, they are always an employee, and they're to be treated like an employee, not a client. And that's true even when their expression of problems looks like many of the clients that we serve. So suggesting that, is there any place that you can go for help or assistance? Would you like any help resolving the issues that are confronting you? Without talking about if the person has a problem in the job, that's what we want to focus on solely, and focus on how do we help them overcome that problem in the job. Where can you go for help with that? Where can you get assistance? Is there anything that you would like from me? But understand that if you don't fix this, I'm going to take the next step, which may include suspending, layoff, or termination.
John, just one point of clarification there. So you had said, you had just said if there's a behavior or the person becomes symptomatic and it's a problem, but wouldn't we want to add to that if it's a problem that's interfering with a person's ability to do the job? Because a person could have a behavior, but it's not
Correct.
Interfering with the job.
And so one of the things that I said in that course of discussion was that we really want to focus on the work behavior and its interference with the job. If it's interfering with their other life, as a supervisor, we want to help ensure that our employees are meeting all of their needs. And if they're struggling outside of work, we want to offer assistance. But our responsibility ends, and we run afoul of a variety of laws if we intrude beyond saying, is there anything that I can do? You look really stressed or troubled. Can I be helpful in a way? And then leaving it up to the employee to decide. If their functioning is not interfering with their ability to do the job, that's solely in terms of the law what we need to focus on. So I want to pull up this next slide, and Tony asked me about it earlier in the conversation of, can we hire a client? This is one of the biggest red herrings that we often have is, well, we can't hire someone who uses our services. And in fact, in rural settings and in most upstate communities, what I would say to all of you is that show me a local hospital in New York State, or in most states for that matter, who is self-insured, who doesn't require their employees to use the services of the hospital for health care at the same place that they're providing services at. We often think of, well, we can't hire a peer because they get services here. Well, getting services here does create a potential for role confusion, but some people can handle that quite fine. That's a discussion that should be had on an individual basis, not presume that we're never going to hire someone from here, because on the face of it, potentially that violates EEOC at the federal level and could subject you to litigation. And certainly, if a recipient were to call our office and ask for assistance and say that a provider refused to hire them simply because they were getting services there, I can assure you we would be advising that individual to file an EEOC complaint and supporting them in doing so. Because on the face of it, it flies in the face of equal opportunity. It is, in fact, disparate treatment, which is the legal definition of discriminatory behavior. So, can we hire a client? The answer is absolutely yes. If you're hiring someone who receives services at the same place, you need to have an honest and frank discussion with them about how do they keep separate what occurs in services versus when they're providing services. And in rural settings, this becomes critically important because the only job in town may be the one provider who provides services in a given area. In a larger urban setting, we may try to say, well, we would prefer if you got services from a different team than what you provided services on. But to say that you can't be hired because you get services here may in fact fly in the face of federal discrimination statute and subject you to discrimination litigation. So, ongoing challenges? Well, there's a couple challenges when you hire people with disabilities. One is dealing with illness and time off. And this becomes one of the paternalistic traps, because we often see anytime the person wants a day off as a sign of decompensation. Many clinical staff say, and non-clinical staff say, I need a mental health day. I just need a day off. And that's perfectly acceptable. But when a person with a psychiatric disability says, well, I need a mental health day, we often begin to pathologize that. So we need to be careful that we don't do that. People need time off. People with psychiatric illnesses get physically sick. And sometimes they need time off to even deal with their mental health issues. We need to deal with the issue of disclosure. How much do we disclose and when? It's absolutely inappropriate to ask, where are you getting treatment? Who's your psychiatrist? I want to talk to your therapist. I want to know what medications you're on. We don't ask that of our other staff. We don't ask it of our staff who we know have heart conditions. We don't even ask it of our staff with cancer. We need to treat all people with disabilities alike. Now, if they're using their lived experience to share with other people, the individual should make the decisions about what and how much they wish to disclose and when it is appropriate to engage people in that process. Simply telling my story is not always appropriate for even me to do, only when it makes the point to accomplish the job that I'm set out to do. The issue of boundaries becomes one as well that we often have trouble with, because professional staff are in a lot of ways prohibited from having relationships with the people that they provide supports to. And yet peer staff, by the very nature of being a peer, will often have relationships with people outside of work, which may confound the workplace environment because you're not used to dealing with that. Remember that to be a peer means I need to be a peer. And so having those relationships is a natural, normal part of the process. Now, as I've talked with clinicians around the country about this, we often say, the boundary issue is one of these red herrings, because in psychiatry, we set up these artificial boundaries. But if I talk to my lawyer, I often go to dinner with my lawyer and his wife. We have a relationship outside of that. If I talk to my accountant, we have a relationship outside of our professional relationship. Can they exploit that? Certainly they could. The issue is exploitation, not the clear, rigid boundary lines that we've historically created. And so ensuring that people are not exploited in the boundary relationships becomes critically important. Not that boundaries need to be a little more flexible in dealing with peer staff. There's actually an excellent publication by NICL, the National Independent Living Center Council, which talks about boundary issues for staff in independent living centers. It can be very helpful if you're dealing with those. And then, of course, the entitlement issue that I've already mentioned. The last couple of minutes before we go to questions, I want to address the Dear Medicaid letter. All states were sent a few years ago a Dear Medicaid Director letter, which says that self-help and peer support is something that Medicaid itself is recognizing, and hiring staff with lived experience is something that Medicaid itself promotes and supports. Now, that said, they went on to say that there's some guidance that you needed to think about. One is supervision's got to be provided by a competent mental health professional, that the amount and duration is appropriate with the acts that are being performed, that care coordination is coordinated in the context of a comprehensive individualized plan of care that includes individualized goals, and states should use person-centered planning. It went on further to say that training and credentialing needs to be completed. Now, in the letter, they looked at peer billable Medicaid services, and so what they said there, so I want to differentiate, so those of you that are peers on the call, don't say that I said we've got to have statewide credentialing. That's not what I said. What the Dear Medicaid Director letter said is that if your state's going to use peer billable Medicaid services, then there needs to be a state-level certification and competency. Now, that said, as a local provider or local practitioner, you need to credential your staff. You need to credential them in the same way you would credential professional staff. What competencies and skills do they have? What are we asking them to perform? Are their skills and competencies consistent with what we're asking them to perform? Therefore, they're credentialed to do this function. So with that, I just want to highlight a couple things, and then Tony will go to our questions, which is all of our webinars are now archived on YouTube, and you can find them at this address. So I want to thank Tony for following up on that.
Most of them from the last 3 years. Most of them.
Okay. And our June 6th, we have an upcoming webinar on family participation, a basic one-stop early intervention approach to an elusive challenge. That's available, and you can sign up for that webinar. So, Tony, let's go to the last few minutes we have for questions.
Yep. We got a lot of great questions, and I hope we can get to as many as possible. There are two things, though, that I just wanted to touch base with you on before we get to those. So one of them has to do with the credentialing issue, because we do have several questions around credentialing. And you and I had a conversation a while back that I thought was really profound to talk about for a second. When people ask me about what credentialing agencies are there in New York State before we can hire a peer, what I usually ask them is, well, what's the job description? What are the skills that you're looking for in the person? And the thing that you had said that really struck me was that, well, what that seems to say is that they don't know what they want from the peer yet, because when you hire like a doctor, you already know what the person's going to do, and they've got their credentialing. But when if you hire a peer without having the job description, you're asking them to bring their credentialing in and tell you what they're going to do.
And so here, that's actually a good example. So let me use and expound on the doctor a little bit more, because if we're a hospital setting, we might hire a physician, but the physician to do what? And so if we're looking at a physician to do brain surgery, then we may want to make sure that this individual has done brain surgery before, and in fact has done it to the level that we as a facility are going to say they are credentialed in our facility to perform that function. We define in advance what we want that doctor to do, because a doctor is a really good example. All doctors are licensed, per se, to perform medical practice, but not all doctors are competent in every area of medical practice. And so looking at what uniquely do I want the peer to do in advance, before I start asking about certification, is part of the core process of identifying who are we hiring and why are we hiring them, before we begin to look at, well, what are they certified and credentialed to do? As an individual provider, we credential all of our staff to do the things that we're comfortable in that staff performing. And the same is true of our peer staff. We need to look at each person individually. What are they competent and qualified to perform? And under whose supervision are they going to do that? So, next question.
Yeah, and again, this is another one of those common global questions. So, and could you just go back to the YouTube link? And so the question is, there seems to be a lot of, like, what about staff with dual diagnosis? We serve people with co-occurring disorders or comorbid disorders. What about hiring staff that also have a substance abuse history?
And so substance abuse histories is one where there's actually a lot of hiring of peer staff. In fact, we have a professional credential called the KSAC, which actually credentials people who have been through the substance use system to actually be professional and paraprofessional staff. And so can we hire someone to do that? Well, the answer is absolutely yes. Do we want to hire someone who's actively using substances? Absolutely not. The difference, though, between substance use and mental health treatment is not escaping either, because an individual who has a substance use history will regularly be practicing the methods to maintain and protect their sobriety. The same is true for people in psychiatric recovery. People will be using a variety of supports and services to regularly maintain and enhance their recovery. We should look at both in very similar fashions because it's the same sort of conceptual framework. So next question.
Can John talk about OMH's experience with its clearance process, namely that peers with criminal records are not more likely to reoffend or to harm peers that they are working with?
Well, there actually is a lot of information about the clearance process. Of all the peers that we've cleared, we have not had one that I'm aware of that has harmed or violated any of the provisions of anything that we would be concerned about. Now, that said, peers are human beings, and they run the whole range and gamut of human experiences. So will they ever break a rule? Well, of course they will. And peers who have a variety of backgrounds are no different than any staff. Staff sometimes break rules. We have to discipline them. But in terms of reoffending and committing to date, we've not had one do that. But part of what we're looking at is, what are you hiring the person to do? So if we're simply hiring a peer because, well, we want a peer, well, you don't have a clear job description. And it's really clear that you don't really know what you want. So defining what we want, what do we want to use that person's skills for what population of people are we using that skill for, can be critically important. And then having the discussion about how do we help maintain the boundaries and safeguards, and how do we help ensure that you're getting the support that you may choose to want and need as part of that process to maintain your own protection strategies and recovery stance becomes critically important.
Okay, so this is a question from one of the people on the webinar. Can someone inform this group that NIAPers created an Academy of Peer Services, and they are doing regional meetings in New York State to launch a web-based peer training program?
Well, let me clarify that. First off, NIAPers did not create a damn thing. And I'm going to say this very emphatically. The New York State Office of Mental Health created and is in the process of looking at a process to help provide skill-based training for peers who are working in the system. There was a competitive RFP issued at which the University of New Jersey School of Medicine and Dentistry won the request for proposal. NIAPers is simply a subcontractor to UMDMJ for only a very small part of this. But the Office of Mental Health is creating the Academy of training courses using the workforce of UMDMJ to execute that on our behalf. And whether or not we continue that and how we proceed in that regard will be up to us. But this is not a NIAPers project. And I just want to be emphatically clear that although NIAPers is a contractor, there are also many other contractors to this. It is not one of their functions. It's in fact an Office of Mental Health. It's hosted on the Office of Mental Health web pages. And in fact, NIAPers' role was simply to help coordinate some community-based meetings and support the UMDMJ part of the process.
Thank you, John. Next question is, what are some suggestions for handling a situation where a peer has worked in a program successfully for a number of years, but due to various comorbid health problems and the need for additional meds for those is not now functioning at a level where the peer can do the job effectively any longer? The peer is dependent on the income and only has limited insight currently to realize the decline in functioning.
So this is kind of the core of paternalism. An individual who we're not disciplining, who's not doing the job, and we're getting into their head about, well, they need the job and they need the benefits and supports, it may be important for this individual to simply look at disability and going on long-term disability again. Even though they've done the job successfully, if they're not doing it now, we do a disservice to all of our employees and to every other peer potentially we might ever hire in the future by not taking appropriate action when an individual who's not performing the functions of their job. And so as a supervisor, am I always worried about disciplining or firing someone who I know is struggling financially or economically? The answer is yes. But I also wouldn't be doing my job if I let someone continue to sit and draw a paycheck when they weren't earning that paycheck legitimately. It devalues the role of peers in the workforce. when we condone and let that happen. And although it's unfortunate, the fact that they have no insight is not the issue of the employer. The fact that they're not doing the job is the issue the employer needs to focus on. Either you do the job, can we help you find supports you need to be able to do the job? And if not, then I need to take appropriate disciplinary action. I hate to sound that hard and cruel, but it really is very clear. And if I stray from those lines, then I'm risking violating federal and state law. So, Tony, we've got time enough, I think, for one more question, and then we'll do a little wrap-up.
All right. Well, what about, we didn't really talk much about subcontracting, and I'm actually going to take control of the webinar here and put up a website for people. So what about the idea of subcontracting or contracting out to peer agencies and hiring peers through there? Because I have had questions about, well, who's really my supervisor? You know, who do I answer to? What about when I have a conflict between what the agency wants me to do and what I've been trained to do according to my peer values? And things like that tend to create additional stressors for everyone.
So one of the great tools that we have is really the ability to subcontract. And if we're only going to hire one peer, it might make sense to contract with the local peer organization to provide that staff. My own office here is really a good example because in our own office, Tony, as you know, a lot of the staff, for a variety of reasons, are contracted employees historically through a variety of places. This is where we're able to get peers to work in hospitals and other environments if we have problems with hiring or supporting them in a variety of ways. And a peer organization can actually be a very valuable asset to subcontract with, to actually provide the supports for the peer that we're hiring. And then if there are conflicts between what their supervisor on site versus the agency that's paying them the paycheck, the two supervisors of each should get together and resolve that, not put the employee in the middle and expect them to somehow have a magic crystal ball to resolve that issue. So Tony, you want to explain what we're at? And you know, I know what it is, and then we'll do a little wrap up here.
So what I have up here now is on the Office of Mental Health public website. I got here, and I'll show you how I got here through, it's right on the front page of the website where it says Find a Program. If you click on the button that says Find a Program, it'll take you here. And then I clicked on right here where it says Advanced Search, which brought me to this page. And you can see, if you want to scroll down here a little bit, and I know it's jumpy for you, and I do apologize, but it's just the nature of the program. So you'll see recipient run. So I toggled that to yes, and then I hit search, or I hit go, and then it gave me a list of 164 programs that were found in New York State that are peer run or recipient run. Now we do include family run in here as well, and if you scroll over where the I is, it gives you the definition of what we're defining as recipient run, and that does include family run programs. But you can look through, you can actually do this by county or by region as well, so you could be able to get something close to your area if that was something that you wanted to consider to take a look at reaching out to those programs to hire some peers. There was one other question on here, and maybe you could help me, John, is that one of the questions was, can you post the videos somewhere else other than YouTube, because OMH policy will not allow us to see the videos?
And we actually do have them posted in several different places. And if your location, you're one of the OMH facilities, and you want to be able to view them, give our office a call directly, and we'll work with your security officer and the local FIC to open that portal up for you to be able to view these videos for peer and other support. And so we'll need to do that anyway for the peers who often use these videos for professional training and support. And so we'll work with your individual facility to help you work out how. So with that, Tony, we're really out of time. I want to thank everyone for participating today and really for your interest in supporting peers as part of the workplace. This is something that's very meaningful, important to our future direction in terms of mental health treatment and service delivery. I want to thank all of you for your attentiveness. We've got a backlog of questions. If we can do some of them as FAQs, we'll put them up on our webpage, FAQs, frequently asked questions. So I want to thank all of you and wish you to have a wonderful day. And for those of you that are peers, be kind to each other and offer support to each other. And professional staff, remember the great value of the work that you do, and look for the people who are in recovery who you've supported, because the anecdotal evidence will suggest that you have not really helped people recover, and the empirical evidence suggests something dramatically different. Thank you all for your time today and for participating in today's webinar. Thanks so much.